The goal of a diagnostic hysteroscopy is to visualize the uterine cavity and evaluate it for pathology. A biopsy may also be performed during the hysteroscopy. In this film, the various parts of the diagnostic hysteroscope, its assembly, introduction into the uterus, and how it is then handled are demonstrated. Take note that the specific hysteroscope shown in this film is equipped with a continuous flow system that allows for the continuous in- and outflow of distension medium, as well as a working channel allowing for the introduction of instruments. Various types of hysteroscopes exist, and a hysteroscopy may also be performed with a single flow hysteroscope without a working channel. Diagnostic hysteroscopies may be performed in an ambulatory care setting or in theatre. Take note of the various components that are necessary to assemble a diagnostic hysteroscope. The camera, fitted with buttons for focus, zoom, and 3 programmable buttons, as well as a sliding lock that may be used to secure the telescope into place. Also take note of the camera cover and the telescope that has a connection to attach the light cable to, and that is generally fitted with a 30-degree lens. Take note of the light cable that has one side that may be attached to the connection on the telescope and one side that can be connected to the light source. Also take note of the sheath of the hysteroscope. Here, a 4.5mm and a 5.5mm sheath are shown that have an input for the telescope, an inflow channel, and an outflow channel, where the inflow and outflow tubes are attached to, and a working channel that may be fitted with a rubber knob. Also take note of the fenestrations at the tip of the sheath that allow the distension fluid to flow back towards the outflow channel. The in- and outflow channels and the working channel may be opened or closed with taps. If the tap is in line with the channel is open, and if the tap is perpendicular to it, it is closed. Take note that the inflow channel is always located closer to the surgeon than the outflow channel. Finally, take note of the instruments: a pair of scissors and a biopsy forceps. These instruments can be inserted into the working channel. The diagnostic hysteroscope is assembled in the following way. The telescope is inserted into the sheath and secured. On securing the scope, a click may be heard. Various securing systems exist, however, and one may differ from the other. The inflow tube is secured onto the inflow channel on the sheath. Take note once more that the inflow channel is located closer to the surgeon than the outflow channel. The inflow channel may also be recognized by an arrow pointing towards the sheath. The outflow tube is secured onto the outflow channel. The light cable is connected to the telescope. Finally, instrumentation may be inserted into the working channel if necessary. Take note how the working channel is opened by switching the tap and how the instrument is introduced. The camera is inserted into the camera cover. And the plastic overlying the lens of the camera is removed. The telescope is then secured onto the camera using the sliding lock that may be used to secure the telescope into place. And finally, a tape may be applied over the telescope to seal off the camera cover. Take note of the fully assembled diagnostic hysteroscope. With its camera that is attached to the telescope with a light cable attached that is inserted into the sheath with the in- and outflow tubes attached to the in- and outflow channels, and also the working channel on the sheath through which the instrumentation is introduced. Also take note of the tip of the sheath with the lens of the telescope at a 30-degree angle. This allows for the circumferential inspection of the uterine cavity while minimizing the need for manipulation of the hysteroscope. Take note of the working channel that functions as an outflow channel for the distension fluid. And also take note of the inflow channel through which the distension fluid enters the uterine cavity. The telescope lies within the inflow channel. Here, scissors can be seen coming out of the working channel. Take note how the 30-degree lens looks onto the scissors, giving the surgeon a clear view of its instrumentation. The patient is placed in the lithotomy position with her legs in stirrups. Take note that footage of different patients was used in this film to demonstrate the handling of the diagnostic hysteroscope. The inflow tap is opened to allow for a flow of distension fluid through the inflow channel, and the outflow tap is opened as well to allow for the evacuation of the distension fluid through the outflow channel. Take note of the opened, in, and outflow taps. Care should be taken to open the outflow tap before the introduction of the hysteroscope into the uterine cavity to prevent excessive intrauterine pressure. The hysteroscope is introduced into the vagina up to the external os of the uterus. It is advised to aim the hysteroscope dorsally towards the posterior fornix after introducing it into the vagina, in order to facilitate the identification of the external os of the uterus. Here, the view from the hysteroscope inside the vagina can be seen. Take note of the rugged vaginal epithelium, the external os of the uterus, and the cervix. When an angled lens is used while introducing the hysteroscope into the external os of the uterus, it is advised to keep the external os of the uterus at the bottom of the screen, on the same side as the light cable connection. The light cable connection always corresponds to the tip of the hysteroscope. Due to the angled lens, the external os of the uterus is actually right in front of the tip of the scope when it is seen at the bottom of the screen. Keeping the external os of the uterus at the bottom of the screen ensures that the hysteroscope is introduced in the most efficient and least painful way. Even though a diagnostic hysteroscopy can usually be performed without the need for anesthesia, it is advised to use local anesthesia if the patient experiences too much pain during the introduction of the hysteroscope. The hysteroscopy should then be stopped and a paracervical block should be performed. The block is most commonly required with nulliparous women, in whom the cervical canal is more narrow. Local anaesthetic is administered by first introducing a vaginal speculum, and then injecting several milliliters of local anaesthetic around the external os of the uterus, making sure to retract the plunger before injecting the anaesthetic to make sure the needle is not introduced into a blood vessel. Take note how the cervix is grasped with the forceps and how the cervix is injected with local anaesthetic after retracting the plunger and checking whether no blood is aspirated, confirming the needle is not introduced into a blood vessel. The hysteroscope is introduced into the external os of the uterus and passed through the cervical canal and the internal os of the uterus until the uterine cavity is reached. Take note of the palmate folds of the cervical canal. It is advised to instruct the patient to exhale during the introduction of the hysteroscope into the cervix, in order to make the introduction more comfortable. Having the partner next to the patient may also help the patient relax. Take note of the internal os of the uterus and the uterine cavity, which can now be clearly seen. The uterine cavity is inspected for pathology, and both the left and right uterine ostium are inspected as well. Take note of the left uterine ostium and the right uterine ostium. It is advised to always hold the camera in the non-dominant hand while handling the hysteroscope, and to only rotate the view from the telescope by rotating the light cable, and never rotate with the camera. Rotating the camera will cause shifting of the horizon and will cause disorientation. Here the surgeon is seen rotating the light cable to inspect the uterine ostia. Take note that the black indentation on the screen indicates the position of the light cable. The light cable is on the left side for the surgeon, and so is the black indentation. Also take note that the surgeon looks along with the light cable. The light cable is on the left side for the surgeon, and the left uterine ostium of the patient is visualized. Here the surgeon is seen inspecting the right uterine ostium by rotating the light cable. Care must be taken to inspect the uterine ostium predominantly by rotating the lens with the light cable, and to minimize manipulating the entire hysteroscope, in order to prevent causing the patient unnecessary pain. If necessary, scissors may be introduced through the working channel to transect any adhesions, or a biopsy forceps can be introduced to take a biopsy. Take note that both the light cable and the instrument are handled with the dominant hand, while the non-dominant hand keeps the camera steady at all times. After the diagnostic hysteroscopy is completed, the inflow tap and the outflow tap are closed, and the hysteroscope is removed from the uterus and vagina.